Greetings and a warm welcome to all the dignitaries present here. I am Asya from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clernet serves as the digital partner for this event hosted by the Oncology Integrated Society, and the focus for today's session is molecular basis of MGT of oral cancers and update. Now I'll go ahead to play the Saraswati Vandana.
You can proceed with lamp lighting then, if it's not coming.
Just a moment, ma'am. Yeah.
ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः हंसवाहिनी नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः हंसवाहिनी नमो नमः.
So now I'll request Dr. Dipti Chaturvedi, ma'am, to begin today's session. Over to you, ma'am.
Okay, with the blessings of Ma Saraswati, I welcome all of you. Good evening. On behalf of the Onco Integrated Foundation, it's my proud privilege and an honor to extend a warm and gracious welcome to all the gathered participants for this academic deliberation on the topic molecular basis of management of oral cancers and update. We are deeply honored by the presence of our dignitaries, especially the guest of honor and the National AROI President, Professor C.S. Madhu, and also President of UP ARI, Senior Consultant Kamla Nehru, Dr. Sonia Tiwari. We also extend our sincere regards to the expert panel and chairpersons whose collective experience and scholarly insight will enrich us with the scientific value of this session. Oral cancer continues to represent a major oncological challenge, particularly in the Indian subcontinent. The transition from conventional treatment paradigms towards molecularly guided precision oncology has transformed our understanding of tumor biology, therapeutic targeting, prognostication, and personalized care. Today's discussion promises to provide meaningful insight into these evolving dimensions of oral cancer management. We are especially grateful to our speaker, Dr. Suboohi Jafar, for sharing her expertise and academic perspectives on this important subject. I now hand over the dais to Dr. A.K. Chaturvedi, who is the president of OIRF and also the owner of Dr. Chaturvedi Cancer Hospital, who has been past president of UPARI and has many feathers to his credits and many extra fellowships and trainings. To introduce our guest of honor, Dr. Madhu. Dr. Chaturvedi, please.
Thank you, Dr. Dipti. It's both a privilege and a profound honor to welcome our distinguished guest of honor, Professor Dr. C.S. Madhu, an eminent academician, visionary oncologist, and pioneering force in the field of radiation oncology. Dr. Madhu illustrious career spanning several decades of relentless dedication to oncology, academic excellence, and institutional development stands as an inspiration to every young clinicians and researchers present here today. From establishing advanced oncology infrastructure in government medical colleges to contributing extensively to the national and international oncology forums, his journey reflects leadership of exceptional caliber. A respected teacher, organizer, researcher, and mentor, Dr. Madhu has not only practicing oncology, he has helped shape its growth in India through visionary initiative, academic contribution, and unwavering commitment to patients' care. His association with the premier international organization, including ASTRO, ESCO, ISTRO, ESMO, further reflects the global recognition of his expertise and contribution. Dr. Madhu did his MBBS from Kerala University, then he did DMRT, then MD Radiation Oncology, then DNB, and he has got certificate in palliative care from Cardiff University, UK. Then he did advanced certification course in molecular oncology, which is the topic of today, from Thomas Jefferson University, Philadelphia. He was associated with many prestigious institutions as a faculty, assistant professor, such as Regional Cancer Center and Medical College Trivandrum, University Department of Clinical Oncology, Kupris Hospital, Leeds. He got fellowship there. He was assistant professor and professor in Medical College, Kottayam. He had fellowship in UICC, ICRET, from Rush Presbyterian and St. Luke's Medical Center, Chicago. WHO fellowship from Memorial Sloan Kettering Center, New York, USA, and Memorial Hospital, Long Beach, California. He has got many papers and presentations, endless presentation. We have got 13, 14 pages of his curriculum vitae, which we are just omitting because of lack of time. Right now, he is working as senior consultant and head of Department of Oncology, Kochi, Lourdes Hospital, Pachalam, Kochi, and is visiting consultant oncology, MJKM Cancer Center, Cherthala. So now I request Dr. C.S. Madhu for his pearls of wisdom, because today's topic is very interesting and he is very much interested in talking on this also. So Dr. Madhu, please. Dr. Madhu?
Yes. Yeah. Can you see my slides now?
Yes, sir, it's visible.
Yeah.
Yeah.
Actually, thank you, Dr. Chaturvedi, for the nice introduction. And you must be remembering that we both had journey in radiation oncology almost at the same time, and we used to meet in so many international conferences and national conferences, all the national conferences. But only last 3 or 4 years, you must not have been attending regularly. Otherwise, you were a frequent attendee, and I used to enjoy your company. Anyway, thank you very much for giving me an opportunity to say a few words, which I always wanted to tell our younger generation. Of course, the topic is oral cancer and the molecular aspects of oral cancer. But definitely, just before that, as a catalyst, let us go through some of the slides quickly, and then we can go to the subject proper. So, when we all started a career in radiation oncology, there were no medical oncologists, there were no palliative care physicians, and there were not many surgeons. The surgical oncology as a specialty was not there. Subsequently, now Cancer Institute started the DM and the MCH, etc. And now there are plenty of plenty of consultants in surgical oncology, medical oncology, palliative care, etc. And our thing. But so those days, the radiotherapy used to be the predominant modality in the treatment of oral cancers. So, but subsequently, what has happened is because of the some crowding of specialists, etc. Now, I don't know whether radiotherapy is pushed to a corner. And I just wanted you to just open your eyes. So here, this is the TNM staging. Here, what you can see is gradually, unlike the UICC TNM staging of 1981, 82, etc. Now, even in the TNM staging, you can see the depth of invasion, 5 millimeters. So actually, if a randomized clinical trial is to be conducted regarding primary radiotherapy and versus primary surgery, it is not possible because the surgeons, they have established that the primary treatment is always surgery and the radiotherapy as only a post-operative adjuvant role. And added to that, now a lot of new developments like the into play, and even the molecular aspects like circulating the decision for the need of adjuvant postoperative radiotherapy or not. But as a doctor who was trained by one of the two of the Manchester trained radiation oncologists, namely Professor Krishnan Nair and Professor T.K. Padmanabhan, I still believe that there is a need for radiotherapy as the primary treatment. He always used to say that the surgery should be only a salvage treatment when radiotherapy fails, because we will be able to preserve the anatomy. Now, let me come to one of the slides. This is a carcinoma of the buccal mucosa, which you all can see. But today, if this patient is seen in a Tata Memorial Hospital, say, for example, our Anil De Cruz or others, Dr. Anil De Cruz, I respect him a lot, but definitely it will be a surgical treatment. And some of them may say that verrucous carcinomas are not sensitive to radiation, and that radiotherapy will produce harm than good. I have a publication on verrucous carcinomas. It is not like that. Here you can see today's fashion is to give a concurrent cisplat, but the Manchester used to give concurrent methotrexate, and this is actually this treatment, this mucosal reaction which you see. It is a sharp mucosal reaction produced not by linear accelerator, by cobalt with a beam-directed radiation treatment. You can see the entry point of the anterior oblique field. So, so this is what we used to do when when I was in Trivandrum, and then subsequently in Government Medical College, Kottayam. And you can see there will be abundance of tumor infiltrating lymphocytes here, unlike IMRT, where you may be injuring a lot of normal tissues all around, but IMRT has gained more momentum, and beam-directed radiotherapy is now pushed to a corner. And after some time, everything subsides, the patient gets cured. Here is also another case, buccal mucosa, getting excellent local control with radiation treatment. This is, again, primary carcinoma of the tongue. Today, if we go through the NCCN guidelines, they will say that immediately the patient will have to undergo surgery. You can see this is the tumor, but this is the result after the external beam radiation treatment. It's a beam-directed radiation treatment. You can see there is nothing has happened for his mustache. This is actually a well-differentiated carcinoma of the dorsal brachytherapy, the preloaded interstitial brachytherapy of those days. Now, preloaded brachytherapy is not there in oral cancer management at all. But I would like to say that the radiation hazard of it is far less when compared to an angioplasty done by a cardiologist. So the radiation hazard is far negligible when compared to that. This I had a lot of discussion with Dr. Thayalan, the physicist in Chennai, and that is the fact. But anyway, it is gone from our hands now, but it has got a lot of advantages, especially because in many of the government medical colleges, you may get a lot of early carcinomas of the oral cavity, tongue, buccal mucosa, etc. And those days, surgeons never wanted to do, they never had the time to operate, etc. And these patients were getting excellent local control with the interstitial brachytherapy. But the advantage of this procedure is that this can be done without anesthesia. But now what has happened is, because of this cumbersome afterloading procedure, now it has become more or less a surgical procedure, and the number of cases who taken up for brachytherapy has come down drastically, not in almost all government medical colleges and regional cancer center Trivandrum at present. So this is the thing, the mucosal reaction is perfectly localized, and the tumor infiltrating lymphocytes, their role is can be very well taken into advantage. And this is the result of the treatment. You can see excellent local control. So this is a primary carcinoma of the tongue. Again, a verrucous lesion. But today's radiation, today, if this patient is seen in some of the cancer centers, they will immediately do total glossectomy. But beware, this can be managed without total glossectomy. This is again a young lady with a primary carcinoma tongue. But you can see the mucosal reaction. This is produced by interstitial brachytherapy, preloaded. But today it is not possible. Those days, people used to do a mandibular nerve block, and then an interstitial brachytherapy is done quickly without, and there may not be much of a radiation hazard to the person who is doing. Of course, you can use a lead mobile barrier and do it from behind and do it quickly, and there may not be much of radiation hazard. In fact, it was far less when compared to what a doctor is getting when an angioplasty is done. This is the result. This is again a primary carcinoma of the tongue. This patient actually had a IMRT, but as we all know, brachytherapy is definitely the treatment of choice, but because of the lack of facility, this patient had a IMRT, and of course, it produced good results. So often you may have to combine sometimes a preoperative followed by preoperative radiation followed by surgery or vice versa. And age is not a barrier. At 82 years of age, this patient had a radiation treatment. 10 years he was disease-free. Then he developed a small recurrence, and at that point of time, he could undergo surgery. So the thing is, radiotherapy has definitely a big role to play, and it may be possible for many of our patients to have their anatomy preserved. But of course, because of the multidisciplinary care, etc., and the dominance of surgeons, etc., now I don't think in very many hospitals this is taking place. Of course, there are patients who come directly to me, in which case I will have the discretion to use radiation, the primary modality of treatment. But having said that, we all know that a lot of new developments have happened in the field of oral cancer management, and today's further discussions are going to be on the molecular aspects and how it can be utilized for personalized cancer care. Of course, radiation oncologists will have to make use of all the advancements like the circulating tumor cells, the percent of circulating tumor cells, and the decision regarding the need of postoperative radiotherapy. Then, of course, the extreme trial has established that the pembrolizumab has got a big role to play in the management of cases where especially the CPS score is, or the DPS score is reasonably good, 10 or more, or even more than 1. So that is the case. But even though there are so many trials on the post-operative immunotherapy, etc., why not there be a utilization of immunotherapy along with the radiation? That is something, I had shown you one case where it had produced excellent local result. But if the immunotherapy is also added to that, I personally feel that the results will still go up. Anyway, I don't want to prolong much. I just wanted to give this brief introduction for you all to think of all this. And then let us hear more about the molecular aspects of the oral cancer management. And that's all. Thank you, Dr. Chaturvedi, for giving me the opportunity.
Thank you, Dr. Madhu, for excellent overview of these things, radiotherapy. But now, since the today's topic is molecular oncology, so I request Dr. Diksha to introduce the chairpersons for that. Dr. Diksha.
Thank you, Dr. Sir. I would like to introduce Dr. Sonia Tiwari, ma'am. Ma'am is a senior consultant, Kamla Nehru, Prayagraj, President UP AROI. Welcome, ma'am. Dr. Surbhi Gupta, ma'am, Ma'am is an HOD of Department of Radiotherapy from Agra Medical College. Welcome, ma'am. Dr. Amrita Tripathi, ma'am. She is a senior consultant radiation oncologist at Sri Krishna Hospital, Baikaka University, Karamsad, Anand, Gujarat. Welcome, ma'am. Dr. Mehmoon, sir. Sir is an associate professor at BRD Medical College, Gorakhpur. Welcome, sir. Would like to welcome Dr. Sameer Batham, sir. He is working as a senior consultant in the Department of Radiation Oncology at HCG Cancer Center, Ahmedabad. Over 14 years of experience. Dr. Rahat Hadi, sir. Sir is examiner at RML, KGMU, AIMS, AMU, PGMR. Sir is guide to many CDRI projects. Sir is an ex-assistant professor at JIPMER, Puducherry, and many other publications to his concern. Welcome, sir. Dr. Meenu Gupta, ma'am. Ma'am is HOD of Department of Radiation Oncology at Government Kathua Medical College, Jammu, Uttarakhand. It's a unit of Homi Baba Cancer Hospital and Research Center, Tata Cancer Center, Chandigarh. Welcome, ma'am. I would like to introduce Dr. Sonia, ma'am, to introduce Dr. Suboohi, ma'am.
Diksha, I don't have Suboohi, this thing.
So, Dr. Diksha, Amrita has been told to introduce. I think for Amrita, you have it now.
Sorry.
No, I am sorry for this embarrassing situation. Dr. Amrita, you have her CV.
Yes. Good evening, everyone.
Yeah.
So it's a privilege to introduce today's speaker, Dr. Suboohi, who is a practicing radiation oncologist. She has done her MBBS from Government Medical College, Haldwani, and her residency from Max Super Speciality Hospital, Vaishali. She has also worked briefly as in the Department of Medical Oncology at Safdarjung Hospital, followed by a brief stint at KMC Cancer Institute, Meerut, and Crest Galaxy Cancer Institute, Moradabad. Finally, she has settled and currently working as consultant in oncology at Apex Super Speciality Hospital and Postgraduate Institute, Varanasi. She has actively contributed to academic oncology through multiple national presentations, publications, and faculty engagements through CMEs, masterclasses, and national oncology forums such as this, making her a valuable voice in contemporary radiation oncology. We are delighted to have her as the speaker for today's webinar. Over to Dr. Suboohi. Please take the lead. Thank you.
Thank you so much, Dr. Amrita, for such a nice introduction. First of all, I would like to thank A.K. Chaturvedi sir and Dipti ma'am for giving me the opportunity to present today's topic, that is molecular basis of management of oral cancer. And it's an honor to present my PPT in front of Madhu sir, as well as our esteemed experts like Sonia ma'am, Surbhi Gupta ma'am, Meenu Gupta ma'am, Hadi Rahat sir, Mamoon sir, Dr. Amrita, Dr. Sameer Batham, and Dr. Amit Pandey. Without wasting any more time, I would like to start my presentation. Should I start my presentation, Dr. Amrita?
Sure, sure.
Yes, definitely.
Okay.
Sure.
Okay. Everybody can see the slide here? Yes?
Yes, ma'am.
Thank you. So today's topic is the molecular basis of management of oral cancers. I have used these. First of all, I would like to say, if I say anything wrong, then pardon me. And you can always correct me if I say something wrong. These are the sources which I have used for today's presentation. That is SACT Clatterbridge Protocol, NHS Guidelines, Devitt and Hellman 12th edition, NCCN algorithm and references, as well as other review articles. There are some challenges that we face during oral cavity cancer management, like difficulty in predicting the capricious behavior of oral cancer, failure at primary sites, cervical and distant metastasis, and the development of second primary oral cancer. There are various genetic mutations and molecular drivers that are there in case of oral cavity carcinoma, that is P53 tumor suppressor gene, EGFR, PI3K, AKT, mTOR axis, VEGF, and these mutations can affect oncogenes, tumor suppressor genes, and DNA repair mechanisms, leading to uncontrolled cell growth and malignant transformation. So the question arises, why are we putting so much effort in studying these mutations and molecular basis? Because we all know that the incidence of head and neck cancer is rising day by day. It is the most common cancer in case of males, and the second most common cancer if we see as a common site of cancer So the incidence is rising, and because of the causative agent, that is tobacco, there is field cancerization. So the chances of recurrence as well as distant metastasis are higher in case of oral cavity carcinoma. These are various tumor markers that we can use in case of oral cavity cancers that are diagnostic, predictive, and prognostic. The diagnostic markers are HPV status, EGFR targeted tumor, TP53 gene, cyclin D1, and salivary protein circulating tumor DNA, and microRNAs. There are some predictive markers too, that is P53 mutation, overexpression of EGFR and cyclin D1, as well as prognostic markers, that is E-cadherin. There is loss of E-cadherin, then cytokines, matrix metalloproteinases, especially MMP2 and MMP9. So coming on to drugs that target programmed death receptor, that is PD-1. As we all know that PD-1 is associated with CD28 family, and PD-1 is expressed on NK cells, T cells, B cells, dendritic cells, and macrophages. PD-1 binds with PD-L1, and there is that leads to apoptosis of effector T cells that causes immune escape of tumor as well as synthesis of interleukin 10. Synthesis of interleukin 10 suppresses the inflammatory response. So this is the basic mechanism of PD-1 that binds with PD-L1. Now, PD-L1 is overexpressed in 50 to 90% of oral squamous cell carcinoma that is positively correlated with cervical nodal metastasis. And the drugs available against this is nivolumab and pembrolizumab. Coming on to nivolumab. If we talk about indications, then as monotherapy, it is used for the treatment of squamous cell cancer of head and neck progressing on or after platinum-based chemotherapy. The patients that we can include for nivolumab treatment must have ECOG performance status of 0 or 1, and the dosage schedule is it can be administered either via subcutaneous route or via IV route. If we are using subcutaneous injection, then the dosage is 600 mg every 2 weeks or 1200 mg every 4 weeks. If we are giving via IV infusion, then the dose is 240 mg every 2 weeks or 480 mg every 4 weeks. Though this 480 mg is not a routine, it should not be used, and it is an off-level kind of dosage schedule. And if we are using nivolumab along with chemotherapy, that is 3-weekly schedule, then we can give nivolumab as 360 mg every 3 weeks. But it is again an off-label use. Then there are some things that must be discussed with the patient before starting nivolumab therapy. Women of childbearing potential should use effective contraception throughout the treatment and for at least 5 months following the last treatment dose. Pregnancy status should be verbally confirmed prior to each treatment cycle. And if the patient is currently taking steroids or completed a course of steroids in the previous 5 days, the cortisol level should not be requested. On a routine basis, what we do, we get a baseline cortisol level, and then we repeat this cortisol level at every 4 to 6 weeks for the first 6 months of treatment, and then for the next, and after 6 months, we repeat this at 8 to 12 weeks. And possible adverse effect that we can see along with nivolumab are new or worsening cough, chest pain or shortness of breath, diarrhea or severe abdominal pain, jaundice, severe nausea or vomiting, or easy bruising or bleeding, persistent or unusual headache, extreme weakness, dizziness or fainting, or vision changes. If we are giving via subcutaneous route, then it must be administered over 3 to 5 minutes. And we can use different sites for the next cycle of nivolumab, and we can as a part of side effect, we can find the redness and rashes at the site of administration. If we are giving via IV route, then it should be diluted in 100 ml normal saline, and it should be infused over 30 minutes. And if we have a suspicion of endocrinopathies, we should get a thyroid function test, ACTH, serum cortisol, LH, FSH, testosterone in males and prolactin in females. Then in case of renal impairment, no dose adjustment is needed for the patients if the creatinine clearance is more than 30 ml per minute. And if a deterioration of renal function is seen, then it should be considered as a immune-related nephritis, and further nivolumab should not be given. If we are talking about hepatic dysfunction, then it should be administered with caution in patients with moderate hepatic dysfunction, that is total bilirubin more than 1.5 to 3 times the upper limit of normal, or total bilirubin more than 3 times of upper limit of normal, and any level of AST. And if LFT deteriorates during treatment, then immune-related hepatitis should be considered and it should be stopped. Again, toxicities of nivolumab, there may be immune-mediated pneumonitis, the incidence of which is approx 3%, and immune-mediated colitis that is seen in 1% of the patients approximately. Other immune-mediated toxicities are hypophysitis, nephritis, hyperthyroidism or hypothyroidism. Less frequent toxicities are exfoliative dermatitis, uveitis, arthritis, myositis, pancreatitis, and hemolytic anemia. Other non-immune adverse events that we can see along with nivolumab are fatigue, anemia, cough and dyspnea, nausea, decreased appetite, pruritus, rash, constipation or diarrhea, arthralgia. Then again, we can see some lab abnormalities like hyponatremia, hypocalcemia, hyperglycemia, and hypertriglyceridemia. And on the injection side, as we already discussed, that there can be pain, erythema, and rash. And if these are the abnormalities that we see in case of further blood test, that is platelet count is more than 75,000. If it is at least 75,000, neutrophil is more than 1, creatinine clearance more than 30, bilirubin less than 3 times upper limit of normal, and TSH and free T4 are within range or no change from the baseline, then we can proceed with nivolumab. And if there is some grade 3 or grade 4 severe life-threatening adverse event, then it should be stopped. What if there is disease progression? What should be done when we are using nivolumab and there is decreased disease progression? Then 1 year of treatment is equivalent to 13, approximately 13 doses every 4 weeks or 26 doses every 2 weeks. And for monotherapy, 4 weekly cycles are encouraged where possible to reduce patient visits. And in the absence of disease progression, immunotherapy may be restarted within 12 weeks after the last dose only if an adverse reaction remains at grade less than equal to 1 and the corticosteroid dose has been reduced to less than 10 mg prednisolone or equivalent per day. If the recovery for toxicity takes more than 12 weeks plus the cycle length, a treatment break should be done. Coming on to pembrolizumab, for PD-L1 positive with combined positive score more than equal to 1, untreated metastatic or unresectable recurrent squamous cell carcinoma of the head and neck for a maximum of 12 years, for a maximum of 2 years can be used. It should be given either 200 mg fixed dose every 3 weeks or 400 mg fixed dose every 6 weeks. And as we know that we are using pembrolizumab mainly in metastatic or unresectable recurrent head and neck carcinoma. So to reduce the patient visits, because it is not possible many a times to reach the OPD at every 3 weeks, we can use 400 mg 6 weekly schedule. It should be administered in 100 ml normal saline over 30 minutes. For all advanced indications except melanoma, pembrolizumab must be permanently stopped at 2 years. That is equivalent to maximum 35 3-weekly cycles or maximum 17 6-weekly cycles. Then there can be infusion-related reaction and with pembrolizumab. If it is mild to moderate, that is grade 1 or 2 reaction, then we should interrupt the infusion as appropriate and symptomatic management must be given. And if it is severe grade 3 or 4, then pembrolizumab must be permanently discontinued. Coming on to toxicities related to pembrolizumab, there can be immune-related toxicities like colitis, pneumonitis, or hepatitis, fatigue, nausea, cough, diarrhea, rash and pruritus, as well as arthralgia. If we talk about regular investigations that we should carry on while giving pembrolizumab, then before each dose, we should get a complete blood count as well as LFT and KFT along with random blood sugar, LDH. Thyroid function should be done at baseline level, then every 3 to 6 weeks, and random cortisol should be done at baseline level, then every 3 to 6 weeks. If there is toxicity, then we can delay the dosage and we can manage the toxicity, and we can proceed with the next cycle if the platelet count is at least 75,000 and neutrophil is more than 1, AST/ALT is less than 3 times upper limit of normal, bilirubin is less than equal to 1.5 times upper limit of normal, serum creatinine is less than 1.5 times the baseline, and TSH and free T4 are within range or controlled under treatment. Coming on to next group of drugs, that is CDK inhibitors. As we all know that cell cycle is normally regulated by cyclins and CDKs. There can be two types of CDKs, cell cycle CDKs and transcriptional CDKs. If there is altered expression or increased expression of cyclins and CDKs along with decreased expression of CDK inhibitors and regulators such as CYP, KIP, and INK4, then there is approximately 17.2 times increased incidence of oral squamous cell carcinoma. So we can see that CDK plays a major and very important role in incidence of oral squamous cell carcinoma. The drugs that are available as CDK inhibitors are flavopiridol. It is first CDK inhibitor. It is semi-synthetic flavonoid. It inhibits cell proliferation by blocking G2M and G1S phases. It also inhibits the growth of oral squamous cell carcinoma cells in a dose-dependent and time-dependent manner. Coming on to VEGF inhibitors, it is an important molecule in tumor angiogenesis. That is highly expressed in oral squamous cell carcinoma. There are various agents that are counter to VEGF and its receptors. These are multikinase inhibitors like vandetanib and sorafenib, or monoclonal antibodies like bevacizumab. Coming on to vandetanib, it is the main toxicity that we can see with vandetanib is cardiac toxicity, and it is contraindicated in patients who have a baseline QTc of more than 480 milliseconds. The dosage of vandetanib is 300 mg per oral once daily continuous therapy, and it should be continued for as long as there is clinical benefit or unacceptable toxicity. The major toxicities are diarrhea, rash, hypertension, QTc prolongation, ALT elevation, and posterior reversible encephalopathy syndrome. These are the regular investigations that must be carried out with vandetanib. CBC and LFT should be done on a regular basis whenever blood test is done. KFT should be done at baseline, then 1, 3, 6, and 12 weeks after starting the treatment, then every 3 months for at least a year, and thereafter then as indicated. TSH should be carried out at baseline, then 1, 3, 6, and 12 weeks after starting treatment. ECG or QT interval should be performed by the cardiology department. Pre-treatment at 1, 3, and 6 and 12 weeks after starting the treatment, then every 3 months. Blood pressure should be done should be checked on a weekly basis for the first 4 weeks, then as indicated. If there is QTc prolongation, then vandetanib dose must be modified. Patients who develop a single recording of a QTc more than equal to 500 milliseconds should stop vandetanib. But vandetanib has a longer half-life of 19 days. So if there is any QTc interval prolongation, then it is problematic, and any adverse reaction may not resolve quickly. So prolonged QT interval, if QTc is more than 480 milliseconds at baseline, it is contraindicated. If QTc increases markedly but remains less than 500 milliseconds, then cardiologist advice can be taken and vandetanib can be continued. If there is first occurrence of QTc more than equal to 500 milliseconds, then we should stop the treatment until QTc decreases to pre-treatment levels. If vandetanib is restarted, then resume treatment at 200 mg OD. And ECG and electrolyte monitoring should be carried out at a minimum of 1, 3, 6, and 12 weeks after restarting. If there is second occurrence of QTc more than equal to 500 milliseconds, then treatment must be stopped. And if it is restarted again, then the dose must be reduced to 100 mg OD. ECG and electrolyte monitoring should be carried out at a minimum of 1, 3, 6, and 12 weeks after restarting. Then there are other adverse events, as we already discussed, that there can be diarrhea, rash, and for any other grade 3 or 4 adverse reaction, vandetanib should be stopped until the toxicity has resolved to grade 1. And if it is restarted, then as we discussed, it should be resumed at a daily dose of 200 mg. And if the toxicity reoccurs or persists, then it should be then the dose must be reduced to 100 mg OD. Mild to moderate skin reaction can be managed symptomatically or by dose reduction or interruption. And sun exposure must be avoided while on vandetanib due to risk of photosensitivity reaction. And patients should wear protective clothing in sunny weather and apply sunscreen. There are other adverse events of vandetanib, like hepatic impairment. If bilirubin is more than equal to 1.5 times the upper limit of normal, then it is not recommended. If we talk about renal impairment, if the creatinine clearance is more than 50 ml per minute, then no dose reduction is required. For creatinine clearance 30 to 49 ml per minute, the dose should be lowered to 200 mg, and the starting dose could be reduced to 200 mg in patients with moderate renal impairment, and it is not recommended when the creatinine clearance is less than 30 ml per minute. Coming on to bevacizumab, it is a humanized monoclonal antibody that targets VEGF-A. It inhibits angiogenesis and increases the distribution of chemotherapeutic agents to tumor cells by reducing pressure within the tumor and by reducing microvascular permeability. It inhibits biological activity that is mediated by VEGF by binding to VEGF receptors, which in turn reduces tumor angiogenesis and thereupon suppresses tumor growth. There was a phase 2 study conducted by Fury et al. In which they have used a combination of bevacizumab, cetuximab plus cisplatin that was well acceptable in phase 3 or 4B head and neck squamous cell carcinoma, including oral squamous cell carcinoma. This was their trial, that is Fury et al. Phase 2 trial of bevacizumab plus cetuximab plus cisplatin with concurrent intensity modulated radiation therapy for patients with stage 3 or 4B head and neck squamous cell carcinoma. Patients which were included in the study were newly diagnosed stage 3 or 4B head and neck squamous cell carcinoma that received cetuximab 400 mg per meter square loading dose, followed by 250 mg per meter square weekly, bevacizumab 15 mg per kg day 1 and 22, and cisplatin 50 mg per meter square day 1, 2, 22, and 23, concurrently with IMRT, that is 70 gray. The primary endpoint was PFS, and secondary endpoint were OS and safety and tolerability. And the conclusion showed that the addition of bevacizumab and cetuximab to 2 cycles of cisplatin given concurrently with IMRT was well tolerated and was associated with favorable efficacy outcomes in this patient population. So coming on to sorafenib, it is a multi-targeted multi-kinase inhibitor. It inhibits different targets like RAF serine, threonine kinase, c-KIT, platelet-derived growth factor receptor, PDGFR beta, and VEGF-R. It inhibits the growth and proliferation of tumor cells and also suppressing tumor angiogenesis. It downregulates MCL1, induces tumor cell apoptosis. Combination of sorafenib along with radiation results in synergistic effects on oral squamous cell carcinoma cells by suppressing the nuclear factor kappa B activity. The results of preclinical trials suggested that sorafenib in consolidation with chemotherapy increases the anti-tumor effect by prohibiting cell growth, cell migration, and cell invasion. It keeps the radioresistance of head and neck squamous cell carcinoma by it breaks the radioresistance of head and neck squamous cell carcinoma by prohibiting the repair of double-stranded DNA breakage. The dose is 400 mg BD, but concrete studies could not be found that favor sorafenib as to be used in case of head and neck squamous cell carcinoma. Coming on to mTOR inhibitors, there was a study conducted by Liao et al. They observed that approximately 50% of patients suffering from tongue squamous cell carcinoma showed overexpression of phosphorylated mTOR. mTOR inhibitors can be first generation and second generation. The first generation inhibitors are temsirolimus and everolimus. Second generation are PP242, Taurin 1, and PP30. But again, the concrete studies could not be found that favor temsirolimus, that favor mTOR inhibitor used in case of squamous cell carcinoma. There was a study in which they used everolimus as 5 mg per OD along with radiotherapy, but the result was not favorable for everolimus plus radiotherapy. Coming on to drugs targeting EGFR, these are cetuximab and nimotuzumab, as well as tyrosine kinase inhibitors like erlotinib, geftinib, and afatinib. If we talk about cetuximab, then it can be given as cetuximab, cisplatin, and 5-FU, cetuximab, carboplatin, and 5-FU, or cetuximab plus radiotherapy. If we talk about cetuximab plus cisplatin and 5-FU, then the protocol should be used in case of head and neck cancer originating in the oral cavity only, and the intent of treatment should be palliative. Like that is, it is used only in case of metastatic or recurrent squamous cell carcinoma of oral cavity, and the dosage schedule is 400 mg per meter square loading dose along with maintenance dose of 250 mg per meter square. Cisplatin 80 mg per meter square day 1 of a 21-day cycle, and 5-FU 1000 mg per meter square over 24 hours, day 1 to day 4. Then if we are giving if we switch to cetuximab alone after completion of chemotherapy, then it should be given every 2 weeks with a dose of 500 mg per meter square, and the maximum rate of infusion should be 10 mg, should not be more than 10 mg per minute. If we talk about cetuximab plus carboplatin plus 5-FU, then again it is used in case of metastatic or recurrent oral cavity carcinoma. The dose of cetuximab is same. Carboplatin is AUC 5, 5-FU is 1000 mg per meter square over 24 hours. Again, after completion of chemotherapy, cetuximab can be continued every 2 weeks at a dose of 500 mg per meter square. If we talk about cetuximab to be used as a single agent with radiotherapy head and neck cancer, then the indications are locally advanced squamous cell cancer of the head and neck with a KPS score of more than equal to 90%. Patients where platinum-based chemoradiotherapy treatment are indicated, then cetuximab can be used. Again, the loading dose is 400 mg per meter square, and then followed by maintenance dose of 250 mg per meter square from week 1 to 7 of radiotherapy. There are few cautions that should be kept in mind while using cetuximab, that patients with pre-existing heart disease, angina pectoris, arrhythmias, or patients who are taking high-dose aspirin or coumarin anticoagulants, infusion-related allergic reactions, pregnancy status of patients of childbearing potential should be verbally confirmed prior to administration of each cycle. Then coming on to adverse drug reactions, the major adverse drug reactions are dermatological. Main adverse reactions are skin reactions, which may become severe, mainly present as acne like rash, or less frequently as pruritus, dry skin, desquamation, or nail disorders. If there is more than equal to grade 3 skin reaction, then the dose should be then cetuximab dose should be given after resolution of these skin reactions to less than equal to grade 2. If there is first occurrence, then the next cycle should be given at full dose. If there is second occurrence, the dose should be reduced to 80%. At third occurrence, the dose should be reduced to 60%. And if there is fourth time dermatological reaction, then the treatment should be discontinued. If we talk about hepatobiliary side effects, then increase in liver enzymes can be there, keratitis will be there, and hypersensitivity reactions. Hypersensitivity reactions are like infusion-related reaction that can be grade 1, 2, or 3 or 4. If there is grade 1 infusion-related reaction, then we should slow the rate of infusion to a previously tolerated rate. And if infusion rate should be reduced by 50%, and the patient should be kept under close supervision. If there is grade 2 infusion related reaction, then the infusion rate must be reduced by 50%, and then symptomatic treatment must be given. If there is grade 3 and 4 adverse reaction, then the infusion must be stopped immediately. Symptomatic treatment must be given, and further cetuximab should not be given. If we talk about rash, then any grade 2 skin toxicity or acneiform eruption, then we should give some urea-based cream. As this has been taken from SSCT protocol, so they have written a pylazon cream, but this is basically a urea-based cream that should be used regularly, and that patient is compliant with, and we must make sure that the patient is compliant with doxycycline 100 mg OD, and if required, then we can increase the doxycycline dose to 100 mg BD. Oral antihistamine for relief of any itch and analgesia may be of benefit. If there is grade 3 acneiform eruption, that is eruption covering more than 30% of body surface area, then cetuximab treatment must be interrupted until resolved to less than equal to grade 2, and doxycycline dose should be increased to 100 mg BD, and oral antihistamine should be given. And once the rash is resolved, the cetuximab should be resumed to the full dose if there is first occurrence of grade 3 reaction. If there is second occurrence, then the dose should be reduced to 80%, and at third occurrence, the dose should be reduced to 60%. If there is grade 3 acneiform eruption that is not responding to doxycycline, then we should switch to erythromycin 500 mg per oral QID. If there is grade 4 reaction, then it is rarely seen, but cetuximab should be permanently discontinued. So sunscreen and urea-based cream must not be applied to the radiation field when using cetuximab along with radiotherapy. Urea cream should be applied to face, hands, feet, neck, back, and chest twice daily throughout the treatment. And skin exposure should be restricted. And sunscreen with an SPF of 15 or higher must be applied before going outdoors in sunny weather. Coming on to nimotuzumab. Nimotuzumab is a humanized IgG1 monoclonal antibody which has a long half-life as compared with cetuximab. It has lesser side effects such as skin toxicity and immunogenicity. Nimotuzumab 200 mg is given as IV infusion once a week for 6 weeks, plus docetaxel and cisplatin 75 mg per meter square each on day 1 only. 5-FU 750 mg per meter square infused continuously for 8 hours, used from day 1 to day 5 every 21 days. So the dose of nimotuzumab is every once a week for 6 weeks, and this is the chemotherapy regime every 21 days. Coming on to panitumumab, a phase 3 trial did not show any improvement in overall survival in head and neck squamous cell carcinoma, so it was not studied further. That trial was conducted by Hamakawa et al. Coming on to geftinib, it is, as we all know, it is first oral EGFR TKI that prohibits the proliferation of oral squamous cells in a time-dependent and dose-dependent manner that results in cell accumulation in the G1 phase, cell cycle arrest, and cell decrease in the S phase. It sensitizes cells to chemotherapy. Dose is 250 mg once a day, and the side effect is diarrhea and skin rash. Coming on to erlotinib, it inhibits G2M transition and the intra-S phase of the cell cycle. Erlotinib and cisplatin and radiation shows a synergistic effect in growth inhibition of squamous cell carcinoma cells, as well as it is used as a part of oral metronomic chemotherapy. Other than that, lapatinib and capecitabine shows effectiveness in the metastatic form of head and neck squamous cell carcinoma, though the studies were not very much concrete to favor the use of lapatinib. Other targeted therapies are the activin receptor like kinase 1, that is ALK1, belongs to TGF beta and plays an important role in angiogenesis. Delantercept prohibits ALK1 signaling and it is an angiogenic agent. The phase 1 study shows that delantercept shows considerable ability as an anti-cancer therapy in head and neck squamous cell carcinoma. Bortezomib, that is a proteasome inhibitor, primary results showed a 50% control rate in patients having metastatic and recurrent head and neck squamous cell carcinoma while taking low-dose bortezomib. And endostatin, that is a definitive endogenous angiogenesis inhibitor. It inhibits the binding of VEGF to endothelial cells. And endostatin, along with chemotherapy, was efficient in the treatment of head and neck squamous cell carcinoma. Though many studies, I couldn't find a lot of studies supporting these the use of these drugs. So the use of why we are discussing all these things, as Dipti ma'am said in the introduction part, that these molecular markers are used as a predictive and prognostic factors. They have that unveils novel pathways for targeted treatments. It significantly enhances early detection and survival outcomes. Immunotherapy is a breakthrough, improving immune response against tumors, and it is associated with precision that shows great promise in halting tumor progression, as well as it is used for surveillance. That's all. Thank you.
Yes, a very nice presentation. Thank you, Dr. Suboohi.
Thank you so much, ma'am.
Well studied and written. Any comments from Dr. Madhu? Sir, please.
Yes. Actually, thank you very much for the excellent presentation. But I would like to know two things. One is your practical experience with the use of these agents in the overall management of oral cancers. That is one thing. Another thing is, have you personally used this in the post-operative setting, say after a surgery for locally advanced or metastatic oral cancer, immunotherapy as an adjuvant, whether you have tried, and also
Sir,
regarding the circulating tumor cells. Okay.
sorry, sir. Your last question. Sorry.
And in the post-operative setting, that is one thing. And another thing is the employment of circulating tumor cells to decide on adjuvant treatment, whether there is a need of immunotherapy, radiotherapy, etc. Nowadays, people base on the presence of circulating tumor cells. Anyway, your personal experience you can share.
If you don't have a personalized experience, because we are too young, you can have some senior person.
Sir, I have used cetuximab and nivolumab in case of metastatic head and neck cancer as a part of immunotherapy. Nowadays, we are also using another drug, that is tislelizumab, though the indications are only in case of NSCLC and esophagus as well as gallbladder. But we have started using it in case of head and neck cancer also as a low dose therapy. And yes, these are the drugs which we are basically using, and as well as Keytruda also.
And what is the experience?
Ma'am, right now I have started these immunotherapy drugs from the last 3 or 4 months only. So
it will
long-term results are still awaited.
So what is the cost of the therapy? Very costly.
That nivolumab is like is very affordable, and tislelizumab is like if we there is a PAP scheme also, patient assisted program. So they have to buy only one cycle, first cycle, then the second cycle is free, and after 5 cycles, I think the next cycles for the whole year they provide for free.
There
is some PAP scheme.
Dr. Diksha,
I'm audible, Dr. Meenu Gupta.
Yes,
Yeah.
Yes, ma'am. Yes, ma'am.
yes. I want your comments also.
Thank you, thank you. Actually, I am sitting
You
near the
joined late.
Indo-Pak border area, and first of
Okay.
all, lot of I mean, my wishes to Dr. Madhu, Dr. Chaturvedi, and all the group senior teachers and all that. So their
Thank you,
border,
and same to you.
there are sometimes signal problems, but anyhow, yes, it was a nice talk, and the topic selected was very nice, and a lot of thanks for our senior oncologist, Dr. Madhu. Practically, yes, I am 100% agree. What is nowadays the change in the trend of the practice of all our oncologists, like. This is for the students, especially students, because although this is the era of the molecular era, and this is the era of the PET scan and all that, but what practically and personally I am observing, all others might be observing the basic examination. That is very important. The basic history is very important. I have seen in my some meetings or sometime interacting with the multidisciplinary, multicentric, or my own centers also. Sometimes students they only okay, the PET scan is there, but there are the various factors. Actually, we can't ignore the radiation. So what is actually the, if we talk of the molecular era, molecular biology, these tumor markers, they are here to
Connection
actually
lost.
to guide us the direction. Like if we are talking of the biomarkers like HPV. HPV has in the gynae, definitely it has a diagnostic role, and in case of the head and neck cancer, it has the prognostic value whether we should come to the de-escalation of the doses. But we can see the lot of data for the from the West, and our Indian data is also there, but we are catering patient in our practically routine OPD huge big tumors. We all should be agree, only very few cases with a stage 1 or stage 2 their cases. My own experience, because our centers were giving chemo and immunotherapy and this cetuximab and all that, sometimes yes, for some thesis purpose or some research purpose we have tried this agent, but we can't ignore our radiation, which is the main modality, or surgery or radiation, which is actually the main modality of the treatment. They can supplement, and there is also ASCO studies, de-escalate studies, they are there. Cetuximab is not going to be superior to the cisplatin. As far as the initially people they, I remember एज ए यंग फैकल्टी वी आल्सो ट्राइड, थोड़ा सा वो डरते डरते कि थोड़ी थोड़ी डोजेज फिर थोड़ा ज़्यादा, बट नो, इट इज़ क्लियर कट द cetuximab is not superior to the cisplatin. Use of cisplatin for the head and neck cancer, there is no hesitation, we must use these drugs whenever there are the recurrence, or but we have the other options also, re-radiation. We have the technology of the IMRT, IGRT, as Dr. Madhu rightly said. We have forgotten this brachytherapy, where we can see actually no, people are not no, they are actually the touch, they are scared of doing brachytherapy, because once the students won't go for the local examination, so they don't touch the patient. Brachytherapy for the invasive procedure, and this is the comfort zone. They are trying the IMRT, but if there is a local recurrence, there is a localized disease, we must utilize this therapy. Molecular onco, this is the era, and they can guide us. If the tumor are HPV positive, we are knowing the prognosis, the patient, they are non-smoker, we can just de-escalate the doses. Nowadays, immunotherapy, nivolumab, or there are other immunotherapy people are trying. People are trying with the full doses, or sometimes metronomic. कुछ नहीं है तो थोड़ा थोड़ा करके हफ्ते में थोड़ा थोड़ा करके दे दे, but that small doses, still they don't have the excellent superior disease free survival or excellent overall survival if
Dr.
we compare with the standard
Cut short, because we will
radiation.
take everyone's opinion. Cut short and tell your experience
Yeah,
about it.
that is the my conclusion in my own experience, because for the research other purpose, chemo radiation, that is the standard of care with the cisplatin.
सही है. Dr. Betham,
True.
anything?
Yes, ma'am. So I
Would you
actually
like to add?
wanted to comment on what Dr. Madhu sir was asking. Nice talk, Dr. Suboohi. So basically, sir, so this cetuximab is here since long. In fact, during our residency days, only this drug came into picture, and we used it in many of the patients. I guess the indications are very clear. This is mainly, especially when we talk about the definitive setting, we cannot replace cisplatin. It is only for the patients who are not suitable for cisplatin. Uh, Otherwise, practically, of course, sometimes when intact diseases, patients who present with large nodal masses, we usually start with TPF. But when the patients do not respond to 1 or 2 cycles of TPF, then sometimes we try and replace the F with E, the cetuximab, and sometimes, in fact, in many of our patients, we have seen good response with TPE. Uh, Again, in adjuvant setting, when we talk about the again standard of treatment as of now is radiation plus minus cisplatin. Again, the patients who are not suitable for cisplatin, sometimes we tend to offer them cetuximab or nivolumab. But when we talk about nivolumab, cetuximab or nimotuzumab, when we talk about immunotherapies, we started in definitive setting with the low dose trial from Dr. Professor Patil, and we have many patients where we started with low dose nivolumab along with TPF, and the response is fantastic. This is what we have seen in our own practice. In adjuvant setting, again, recently we have 2 trials, the Nivo post-op, which was published recently, and we have many patients where we started with Nivo post-op, but in my practical experience, this is very toxic regime, because the first dose of nivolumab is given 2 or 3 weeks after surgery. Then, along with CTRT, again the patients receive nivolumab, which is with chemotherapy. This is cisplatin. So we all know with our own experience that CTRT with cisplatin itself is very toxic. And when we add nivolumab, in fact, 3 of my 4 patients, the initial 3 or 4 patients, they had severe toxicities, and somehow we had to omit either their cisplatin or nivolumab. Even completing radiation was a big challenge in these patients. So practically, it is, at least what we have seen in our practice, that these regimes are quite toxic. Of course, they have shown survival advantages in the trials, but practically it is quite difficult. As far as the cost is concerned, again, fortunately, we now have an Indian molecule as the patent is over of nivolumab. So the cost has significantly has come down. But still, in view of the toxicities, I'm not sure about the post-op setting, whether how long we'll be using it. I still feel that CTRT with cisplatin will remain a standard of care for a long time. Of course, we cannot deny the evidences. Newer molecules will come and definitely will replace the existing one. But as of now, if you'll ask me, I'm more comfortable in giving CTRT wherever possible. Yes, sir.
Very nicely said.
Thank you.
CTRT ही देते हैं, that is what I feel. डॉक्टर साहब तो वही देते रहते हैं.
Right now,
we don't go for higher
we have
molecules.
requested one medical oncologist. Is he there? Doctor from Lucknow.
Amit Pandena,
Yeah.
he told me today he won't be able to attend. He has written.
Dr. Suboohi, very nice presentation, concise, and everything in details. How to give, when to give, what to give, where to give. So it's really nice. But the only
Tell
thing
me,
is
is there any difference in survival? Toxicity
yes,
तो chemo में भी होती है.
there is difference in survival.
So the trials are there. So even the Nivo post-op, the other immunotherapy trials, they definitely have shown survival advantage, and that's why they are in recommendation.
Yes.
How much? How much?
A few months, basically.
Basically, in any immunotherapy trial, you'll see, and for that few months,
Yes.
like 5 months or 7 months, itna hi window milta extra.
चलो जिसको जीना चाहिए.
One thing is the efficacy of nivolumab, not only nivolumab, the cetuximab, in ensuring control of the disease and the palliation for a good period. That is something which I have come across, and cetuximab is definitely. But the only thing is, patients who are ESI beneficiaries or ECHS beneficiaries, only they will be able to afford. But if this can be given, then it will be worth. Another thing is, instead of the perioperative immunotherapy, I would be happy if doctors like Samir is coming forward to do peri-radiation immunotherapy.
Yes, sir.
Because that also can definitely take care of a better local control.
Right, sir.
So that is something which we have to think of rather than doing away with radiation. And if radiation is going to be interrupted, then it spoils the show.
True, sir. True. So probably we all agree that whenever we consider radiation with systemic therapy, radiation is the mainstay of the
Yes.
treatment.
That's the mainstay of treatment for 90% of cancers.
Yes.
So
And basically, the newer molecules are we are used only for the recurrence in present
yeah,
setting,
definitely.
not as a new adjuvant,
Mainline.
or because there is no much advantage and financial toxicity, as you all know, always. Sometimes you can see the in the CA tongue T1 stage there, if there is a no indication of the histopathologically and other factor, no poor prognostic factor, the guideline says there is no need of the radiation. But you can see in your practice, we also see even in the T stage, patient recur after 1 year or 2 years. So here there is a role of molecular analysis of these newer molecules, why these recurrences occur. So especially the surgical margin is what are the molecular analysis for the surgical margins. So nowadays people mainly focus on these things, ki what are those factors, even the early cases recur. And also the in oral cancer, field cancerization is a problem. So these are the area to study for the newer molecules, how to manage all these things. And
Very nicely said.
Actually, Dr. Sonia, one thing
yes,
I wanted to tell, that is the minimum number of cells for the
yes,
pathologist to
yes,
identify
yes,
that the
yes,
margin is free is
yes,
10 to the power of 6 cells per cubic millimeter. Anything
yes.
less than that will not be
So it,
identified by the pathologist.
yes,
So that
yes,
is why many of these cases who are left without adjuvant radiation, they
yes,
relapse. And then
yes,
you are giving salvage treatment.
yes,
So the
yes.
thing is, there is no go, but you have to be very clever. And
Careful.
when there is
Yes,
only minimum margin, if you leave the
yeah,
patient alone with the surgery, then you will end up with recurrence.
Right.
yes,
So the preference
That's
is
true.
always after anybody has done surgery, just give one radiation. Okay, Dr. Chaturvedi, what do you have to say?
Not one radiation. It's
Hey, do be radiation.
the
One
thing is,
cycle.
first thing, staging is not done properly. Number
Uh,
two, the pathologist, as Dr. Madhu said, they are not able to find out the cut margin whether it is
exactly.
free or not. Number three is the tumor embolization. What is the status? Perineural infiltration. What is the status? Type of malignancy. There are so many things. So you
Factors.
can't say that the radiotherapy cannot be given. I think there is no
It
harm.
must be given.
There is no harm in giving radiotherapy.
Mm.
It's better to err on right side rather than suffering
Yeah.
from recurrences. So we have to try these things, and we must consider patient to patient. You have to tailor the treatment as per the requirement. It's nothing standard. These are all guidelines. So they are guiding you to do like this. But disease has not read the book nor the guidelines. It progresses on its own. But the use of these monoclonals and immuno
therapies.
drugs, immunotherapeutic drugs, they are definitely going to help us. There are certain drugs which are very effective. Nivolumab we have already used, and now Pembro is also available. So
So
in
how
certain
you get
diseases,
this free medicines you were saying?
No,
Through
no,
them?
you can't get. Only nivolumab is available in
in
Apex.
Apex
Apex.
available.
There
क्या
is
बोल
CM
रहे
fund
हैं?
also. There are a few patients who
हाँ,
apply for
CM
CM
fund.
fund and हाँ, so they receive at मतलब like 2.5 lakhs rupees. So we talk to MR and अगर कोई ऐसा PAP program होता है that fits in like तो we start that drug. Otherwise तो TPA
PAP
patients,
program. PAP program means like how you come to know PAP
patient
program?
assisted program, ma'am.
अच्छा अच्छा.
When
MR is running. Companies are running like that.
अच्छा.
Otherwise, the TPA, the things they are supporting. There's no other way. Government is not supporting. They are giving only
Government
company
is not
मजबूत.
supporting because there is no much advantage of
Yeah,
using
not
these
much of
drugs.
advantage.
So that's why they are not supporting.
Yes.
They are the only the people who are affording, or they have, if any, government this thing, CGHS or the
That's like
government
a
servant.
guinea pig. They're using the patient as guinea pig
Yes, only
and
the funded.
experimenting the drug over them.
Yes.
And because I myself saw very closely a friend of
Even
ours,
I
उसको
have
भी
experience of nemotuzumab, also concurrent nemotuzumab. It is not very effective.
Yes.
Some response, but still the patient locally advanced cancer, nemotuzumab, cetuximab with concurrently given in with radiation, not much advantages as compared to cisplatin.
and ma'am, sometimes
But
there is advantage for the first
yes,
few cycles, like two,
yes,
three
yes,
cycles,
yes,
and then
yes,
it
yes.
stops
Then it's
working.
Yes.
same. Yes,
So basically,
it will remain
nemotuzumab
same. That
alone probably has no, we don't have any evidence of using nemotuzumab alone. And
yes.
probably nemotuzumab alone or carboplatin, they more or less acts like placebo only. If you
Yeah.
are considering nemotuzumab alone or
Yes.
at all considering carboplatin alone, they
Yes.
hardly will have any side effects. But I'm not sure about the effects as well of these drugs.
Effects not much effective.
Sometimes it is always better to use metronomic treatment.
Yes,
The
yes.
older ones. They are more effective than paclitaxel
no,
and
they are tried and tested. These
Yes.
things have to be
No,
tested.
sometimes
It will
these
take time.
That's why the molecular biology has come in the play.
Yes.
You have to decide, and it's a long way to go. We have to find out which particular disease will respond to which particular drug. It's just like sensitivity medicines. So, thank you so
Sensitivity
much,
and the
Dr.
personalized
Yeah,
treatment.
and personalized treatment. Thank you, Dr. Suboohi and
Thank you, sir.
Dr. C.S. Madhu, Dr. Sumil Batham, Dr. Sonia, and where is Dr.
Amrita.
Rahat? I can't see him. Dr.
Thank
Rahat?
you all.
अरे
सर आई एम
राहत
है
आदि हाँ एक शब्द नहीं बोले तब से
यस एक शब्द
थैंक यू से पहले
मैडम आप इतने अच्छे अच्छे शब्द बोल रहे थे मैं सुन रहा था
हाँ तो यू
और
आर हाइडिंग बिहाइंड मैं आपको
नो नो
देख
नो
नहीं पाई
आई वाज हियरिंग एवरीबॉडीज ओपिनियन एंड इन द लास्ट
नाउ यू
माय
गिव योर्स
कंक्लूजन इज द सेम दैट
ओके
it
थैंक यू सो मच
is not much effective in comparison to price, and so much toxicity is there, and the survival is only in the tune of few months only. So these are the
No,
conclusions.
no,
So that's the reason we are not using.
actually, sir.
ये तो आप
Actually,
कह ही
sir,
नहीं सकते अगले
every
को एक
every
महीने
day
जीना है
counts, and
Yes.
yeah you can't say that
the excellent palliation which is achieved with the Tata protocol in say recurrent head and neck malignancies, and also the nivolumab, the cetuximab in the palliative setting, etc. One cannot forget, because when you are in the situation, you can imagine, every day of survival is important, and if you get few months, then it is good enough, and then from there you start. New
Yes,
treatment
again.
will evolve, and then you will have a further survival will be extended. So that should be the way in which we are looking forward to
yeah
things.
Yeah.
go on
Sir,
seeing
sorry to say, sir, but due to cost factor, not
yeah
many patients are able to use, as
okay
Dr. Sonia
And
has told.
the thing is, in India now there are a lot of patients, especially patients in the ESI. patients in the CGHS,
Only government
patients in
schemes.
the ECHS. In these, these are not government.
You
Government
can try
do not
them.
handle ESI or ECHS. It will be only in private, and these patients are tremendously benefited by this sort of immunotherapy treatments. That is
So
my
controversies will
perspective.
always be there.
Only
So
thing is
take
provided
home message, guest of honor will give. Take home message, Dr.
And the
Madhu.
take-home message is
that's what
that,
he said.
so many new drugs are evolving, and definitely the survival will get extended. Say the typical example is our colorectal cancer. In 1995, when I was with Dr. Bruce Minsky in Sloan Kettering, the median survival for metastatic colorectal cancer was only 6 months. But gradually, the national protocol came into existence, and there would not have been a statistically significant difference between the various protocols. But
5-6
today,
years.
after so many years, the median survival has gone up to 36 months,
Very good.
and that is achieved, and then now it is statistically different, statistically significant survival improvement. So like that, gradually, if something is cetuximab, if it is coming up, then after some time another drug will take it forward. So like that, it is going to be a betterment of survival and the quality of survival of patients. Thank you.
So very nicely said. And Dr. C.S. Madhu, as he's a national president, so his words are also equally gemstone like. And really, it is that's why we have these platforms for collaboration and evolving and updating already existing knowledge so that we can do patient centric approach and get better results little by little and update ourselves. With these words, I would like to conclude, and Doctor will give the thanks.
Thank you so much
Okay.
for joining us.
Good night to
We really
Thank
enjoyed
you.
today's
Bye.
talk. Suboohi's talk and Dr. C.S.
Very
Madhu.
good talk. Very good talk, Dr.
Thank you,
Suboohi.
sir. Thank you so
Very
much.
nice.
Thank you,
Dr.
Okay.
Dr.
Suboohi.
Soni
Thank you,
and
everyone.
Dr. Adi,
Okay,
Dr.
good night.
Amartya
See you
Tripathi.
in the next session again.
Sure.
Thank you, sir.
Bye.
Okay.
Night.
Thank you. Bye.
Bye, sir.
Good night.
Good
Good
night,
night.
everyone. Thank
Good
you so
night.
much for having us. Thank you.
Thank you so much to all the delegates for joining us, and we'll be glad to conduct a session again with you on our platform very soon. Thank you so much for your time. Have a great day.